Good morning. Let me take this opportunity to welcome everyone to the SAC webinar. We're talking about the key operational, financial, and legal challenges providers will need to address as they and the communities they serve continue to ease COVID-19 restrictions and adapt to the new post-COVID-19 reality. I'm Joy Stevenson-Laws. I'm the founder and managing partner of Stevenson O'Cristo & Coleman. So let me tell you a little bit about SAC to start. SAC was founded a little bit over 30 years ago to ensure providers such as you are compensated and reimbursed for your work for protecting the health of our communities. Today, I'm so proud to say that thanks to your confidence and support, SAC is the law firm of choice for the healthcare industry. I would now like to introduce my colleague and co-managing partner, Rich Lovich, who will be moderating our webinar today. Rich is actually celebrating his 15th anniversary with SAC. He has held a preeminent AV rating, the highest possible granted by the Martindale-Hubbell since 1995, and has been a Southern California super lawyer since 2011. A year later, he was named as a top-rated lawyer, healthcare, by Corporate Counsel and the American Lawyer magazines. Rich is also a member of the nation's top 1% of attorneys. So I'm so happy today to have Rich as our moderator. Rich?
Thanks so much, Joy. Well, it's great to almost see everybody. We missed you. How do you like 2020 so far? Hopefully things are going to get much better. We're very optimistic that it will. We miss coming out and seeing everybody and talking to you folks about the issues that you're facing on an everyday basis. And certainly now we're very happy to be talking to you about what's at the top of everybody's agenda, which is the impact of the COVID virus and how we can help. And we think that we've put together a very unique seminar here. I know you've probably been inundated with a lot of people putting on these type of seminars. Our focus, as much as possible, is going to be on the practicalities of what you can do in terms of dealing with the unique circumstances that we have concerning the virus. And what we mean by that is increasing your cash flow and your revenue. I think that's probably one of the most important aspects of what we do and how we help you folks out. And that's going to be one of the main themes that you'll hear today. Couple of what we call housekeeping items. That's what courts always say when they want to tell you where to stand before the trial starts. This seminar is eligible for AHAM and HFMA continuing education credits. So all you have to do is go through the usual function of submitting these for credit, and there shouldn't be any issue with regard to it being counted and having that benefit as well. The other aspect is, as the seminar goes on, there's a Q&A function on Zoom that you can take advantage of. And please submit any questions that you have that you'd like us to address during the seminar. We'll do as many as we possibly can during the seminar, but as always, one of the strengths
Oh, Rich, your audio. Just, oh, really quickly, sorry.
Sorry, did you lose me? I'm not sure where I was lost. Britt, can you tell me where?
You're good now. We can hear you.
I'm good now. I'm not sure what else, what to go back to. I was talking about the AHAM HFMA credits. Hopefully you guys heard that. The Q&A function on Zoom, we encourage you to use that. Submit as many questions during the seminar as possible, and we'll answer as many as we can, as we always have. Of course, after the seminar at any time, call us, email us, get in touch with us with any questions that you have, either dealing with the seminar or anything else. And in addition, I feel like Dr. George Fishbeck here, here's sacfirm.com. So you know where to contact us, get incredible information with regard to healthcare reimbursement, and find out about us, that kind of thing. Final thing is, probably for your viewing pleasure, the best way of doing this would be using the gallery view of Zoom. That way you'll have as many of the panelists up on the screen as you can. So hopefully this will go off without any technical hitches, and we're just really, really glad that you took the time to join us this morning. What I'd like to do now is tell you a little bit about our panel, and we're very, very honored to have Dr. Ignacio Zarate as one of our panelists this morning. Dr. Zarate is a physician advisor, medical affairs department at PIH Health in Whittier, California. He also is a medical advisor to SAC. Dr. Zarate is a graduate of the UC Irvine School of Medicine and is currently board certified in emergency medicine. He has served in various roles in the Orange County Community Hospital System, including Quality Assurance Director, Risk Management Consultant, and Physician Advisor. Doctor, thank you so much for being with us today. Our second panelist is Chuck Acquisto, who is our partner in our Northern California office. Chuck is, Mr. Acquisto graduated from Loyola University of Maryland and studied law at the University of Baltimore Law School. He's an active member of the Healthcare Financial Management, HFMA, and the American Association of Healthcare Administrative Management, AHAM, and he's also a frequent speaker on healthcare and legal issues. Hello, Chuck.
Hey, Rich. Good to see you this morning.
Thank you. And our other panelist, along with Joy and I, is Dave Maston, who is a partner in the Burbank office. David earned his bachelor's degree from UCLA and his Juris Doctorate from Loyola Law School. He also has a master's degree in theology from Fuller Theological Seminary. His specialty areas include arbitration, settlement negotiations, and mediations between healthcare plans and providers. Good morning, Dave. Thanks for joining us.
Hey, good morning. Thank you. Welcome, everybody.
Absolutely. So what we'd like to do is turn this over to Dr. Zarate for his presentation, and then we'll go on to the other panelists after that. Please take it away, Doc.
Thank you, Rich. Good morning and welcome, everybody. My topic this morning is on COVID-related challenges as it pertains to three areas. The first is case management, the second is capacity and resource allocation, and the third is billing and collections. My aim is to provide possible solutions you can deploy right away. The first area in case management is that the Trump administration processed a variety of waivers. One of these waivers involves the suspension of a 3-day qualifying stay before a SNF transfer or a senior nursing facility transfer. Though I do appreciate our government's good intentions, sometimes a good deed doesn't go unpunished. We quickly realized that when you send a positive patient, COVID positive patient, to a congregate living environment, you're gonna get 20 of them back. As a result, this was experienced at the Washington State SNF system, where almost 200 patients became positive and almost 60 patients died. As a result of that, the California Department of Public Health and other state agencies have announced a all facilities letter, in our case in California, number 2052, which requires SNFs to change the way they manage the congregate living environment. Mainly three main steps. The first is to manage the safety of the residents. The second, to manage the safety of their healthcare providers. And the third, to develop a process via which they would manage all incoming patients safely. At the end of the day, the system backfired. It actually is now more problematic to discharge a patient from the hospital than ever before. It can take as long as 2 weeks to discharge a patient. Here are some possible solutions to this challenge. The first is to aim to discharge patients home or home with home health as appropriate. The second is to set the expectations with our post-acute partners as far as our facilities discharge planning strategy. Most important, the third is to be in close contact or communication with our SNF senior nursing facilities in our vicinity and find out what their intake process is and their COVID patient management capabilities, which is extremely important. There are some that are facilities that are strictly designated to take care of COVID positive patients. The second area is capacity and resource allocation. There's no doubt our hospital volumes hit very low points. However, that is about to change as we see, per the CDC reports, 40 to 50,000 cases daily of new positive patients with coronavirus. The hospital census is about to reach prior levels, I think, and it may even surpass them. So solutions in capacity and resource allocations, the first is to provide personal protective equipment to our healthcare providers and keep them healthy so they can take care of the patients. The other is to expand treatment areas. The exceptions from the Trump administrations as far as the waivers allow us to treat patients outside the facility of the hospital's vicinity. The other is it has relaxed licensing regulations so we can use personnel to a maximum capacity, and most important, to anticipate the need for staff and perhaps offer RN COVID stipends. The third area on money matters, billing and collections. The COVID pandemic has placed a tremendous stress on hospitals. The first one is canceling all elective procedures, and then ED volumes dwindling, sometimes 50 to 60%. Along with that, hospital volumes dwindling 20 to 40%. The American Hospital Association did publish a letter early in May estimating they were going to be losing revenue in excess of $200 billion. The challenge, decreased revenue, mostly due to reduced claims, though denials still play a role. They're alive and well. Some possible solutions to increase revenue is to prepare for the surge and house as many patients as possible. Really important point is to track all outliers, because I think there are going to be some CMS funding to take care of those outlier bills. The third is to start elective procedures in a systematic and safe manner in an area elsewhere from the hospital, since we are waived as far as the requirement to take care of them on hospital premises. In summary, the challenges in these three areas, case management, capacity, and resource allocation, and billing and collections, are very significant, but may be able to mitigate them with proactive planning. Mr. Moderator, the floor is yours.
Thanks, Doctor. I appreciate it. Great presentation. I was hoping for that to be a less seamless or a more seamless transition, but I couldn't unmute myself, so I apologize for that. Chuck, please take over.
Yes, thank you so much. And Dr. Z made some great points. I'm going to build off of that. It was many years ago that I was actually at a healthcare conference when I first heard the term black swan. And in layman's terms, that's when you're in a business and you don't see what's coming, and it totally turns your business upside down. Perfect example would be the music industry and Apple creating iTunes, and it just changed that dynamic. Who would have ever thought that a pandemic with COVID-19 might be that black swan for healthcare? But in many ways, I think we can safely say that might be what happens. So I'm always one of those people who likes to look at the silver lining, the glass is half full. And what, as Dr. Z was saying, one of the things we're seeing both from the local, state, and federal level is they're scrambling to try to pull down some of the restrictions, in particular with telehealth, to make it a lot more easier for the healthcare to be delivered. There's been some, obviously, as Dr. Z touched upon, some issues with that. And hopefully, as we go through, we're going to see more of the restrictions eased and solutions provided. But this is going to be one of, especially for revenue cycle, one of the big streams of revenue coming in the future. So if the providers are not already there, then they should be definitely exploring moving in that direction. Let me give you, for example, today the CMS just released some statistics. When we used to say telehealth, it used to think immediately of rural hospitals. And that was really the case for pre-pandemic. There was on average 17,000 telehealth visits a week. That was pre-pandemic. Now the CMS is producing statistics showing that there's 1.7 million telehealth visits per week. So you could see the massive jump in just a short window of time. Now, as our technology improves, we could see a lot more of this. So there could be many, many avenues for additional revenue stream with the hospitals, especially if you're in a situation in which now the beds are now being occupied, whether it's this COVID-19 or any of the future viruses that might come along. We're going to learn greatly from this experience. So with telehealth, there's again new opportunities, windows for the revenue to be produced. We as a law firm, we immediately put on our lawyers' hats and see that while there's that opportunity, we're also going to see some issues with the reimbursement. Because this is fairly new, and as the CMS is showing, are they even able to handle this kind of volume? I mean, that's a huge jump from 17,000 per week to 1.7 million. They're already digging in and doing some audits and seeing some suspicious activity from providers, in particular, sometimes physicians, wondering the math doesn't add up. It's almost impossible that this particular provider could do that many telehealth in a day. There's not that much, there's only 24 hours in a day. The reimbursement, again, you want to make sure that you're getting paid. It's apples to apples, not apples to oranges. And there's a lot of regulation and guidelines as to making sure that if you've rendered that service, that you're also being properly reimbursed. So if you're not already there with the telehealth, or you're just starting, you want to make sure that you're keeping good track of that so that your revenue is being maintained. And speaking of revenue, one of the biggest issues that we see here is that for 2020, the either postponement or cancellation of elective surgeries is going to have a devastating effect on hospitals all over the country. Whether you're really stuck with a lot of COVID diagnoses or not, you had to be prepared. So there was a large hole. Beds were not being occupied because surgeries were canceled altogether and pushed back into either later 2020 at the worst. And so you're going to have this window from roughly maybe late February, March, mid-March is when a lot of the cancellations start happening, until even June. I think we've seen more of the scheduled surgeries starting to take place for electives. And well, how are we going to recover? That's lost revenue that just can't be replaced. Well, one of the strategies that we advise is really taking a look back. You can go back as far easily as 2018, definitely taking hard looks at 2018 and 2019, the AR, and seeing where are those particular claims from some, at least the bigger health plans, that were either denied and potentially denied incorrectly, or were not reimbursed according to the contract. This is the time to push back and making sure that this revenue that maybe has already been deemed lost could be gained. I always equate it to, when you were a young kid and you needed to go down to the 7-Eleven and you wanted to buy that Slurpee and you just didn't have enough money, you went to the family couch and you started lifting up the cushions and the pillows. Well, that's what 2018 and 2019 is providing for providers, is to start looking back and seeing where there is the potential for some recovery that could fill in this gap here in 2020. It's not going to make it entirely up, but instead of just giving up and moving on with those are salvageable. And according to the contract, you probably still have many legal rights, and you want to make sure that you go ahead and take advantage of that. There are a lot of other issues, but we want to make sure that you address these, and we're always here happy to answer your questions.
Okay.
Thanks, Chuck. So Chuck, telehealth is going to be a major exploding area, and I know we're going to talk about it a little bit later on as well. It's one of the advantages, I think, or the silver linings of the virus, and how we've been forced to work currently under that. And it kind of will dovetail with, I think, what David's going to talk about in terms of conducting electronic arbitrations and mediations and things like that. So thanks, I appreciate it. It was a good presentation. David, please take over.
Yeah, thanks, Rich, and welcome everybody. I actually have 3 issues I wanted to talk about today. The first issue has to do with creating cash flow after a denial from a payer in light of staff reductions. So we all know, as Chuck was talking about, that the hospitals have taken a significant hit due to the coronavirus pandemic. Mostly this has caused issues with payments for outpatient procedures, as Chuck was saying, surgeries and scans and other procedures. And typically outpatient procedures constitute a large majority of revenue for a hospital. So because of these revenue reductions, there have been layoffs, there have been furloughs, there have been reductions of staff, and reductions of staff in the appeals department for hospitals. And this has created a significant challenge to keep the appeals process flowing. We all know that after a denial, if the appeal is submitted as quickly as possible, then the payer, the payer has the opportunity then to overturn the denial and pay the hospital what they were entitled to in the first place. If the appeal is not overturned, then the hospital has a chance to consider whether to send the case to litigation. So we know that the hospitals are suffering financially as a result of the pandemic. Question I would have would be, how are the payers doing? And so I checked, and I looked at the 2020 Q1 earnings reports for all the top players, Aetna, Anthem, United Healthcare, Cigna. Every single one of them beat Wall Street expectations in their earnings report. And all of them noted that their revenues increased. And we're talking about increases of billions of dollars in revenue. So I'm very curious to see how Q2 is going to play out. Q2 is ending, so we're going to be seeing some earnings reports coming at the end of the month and into next month for these payers. So they are not hurting financially, and the hospitals are. So in fact, actually, if you look at the stock of each of these payers, what you're going to see is just like with the rest of the country and the rest of the companies, you're going to see a large decline in stock values starting in mid-February all the way through March. But for the payers, what you're going to also see is a very steep V shape to their recovery. And as of right now, most of the payers have fully recovered to their pre-COVID levels. Some have recovered higher than pre-COVID levels, and some have even are at their all-time high. And there's a reason for that. But the question really becomes, what can the hospitals do right now to help with the appeals process in order to generate cash flow? And here's the idea that we have. What we have used in the past and what we're recommending that you try to use are what we call spreadsheet appeals. Spreadsheet appeals are exactly what they sound like. You take all of the claims that have been denied by a particular payer, and you put them on a spreadsheet, and you give them all the identifying information for each of the patients. And then at the end of each line, you put a blurb about why you think that claim was denied or wrongfully denied or underpaid. Then you attach a cover letter. And the cover letter, you want to indicate that you want the payer to address each of the spreadsheet lines as if they were an individual appeal. Now, what you're going to find is that many of the contracts and provider manuals that you have with the payers will indicate that they're not going to accept this. They're not going to allow for a spreadsheet appeal like this. They want an individual appeal to be done for each individual claim. Understandable, but the hospitals, what we recommend the hospitals do is to reach out to your payer representatives and to say, look, the hospitals have really stepped up in the battle to fight COVID to their financial detriment. And what they're doing is we want the payers to now step up as well and work as a business partner to help get the hospitals through the resulting financial hardship. So and one of the ways they can do that is to allow these spreadsheet appeals. So when we're looking at spreadsheet appeals, what it allows you to do is it allows you to handle more appeals faster with less resources, and especially in a time where you are faced with a decrease in the amount of staff that you have in order to handle these appeals. The appeals are a critical process to move the cases forward, not just because it allows for initial cash flow to come in very quickly, but it also allows you to meet the criteria of contracts and provider manuals to allow the cases to go to litigation. So that is one thing that we highly recommend that you try to do. If the payer allows that to occur, if they say, yes, we will work as a business partner with you, we will engage in these spreadsheet appeals, at least maybe for a certain time frame, we highly recommend that you get this in writing, because down the road, when the case doesn't settle, if it doesn't settle, and the case goes to litigation and we're before an arbitrator or a judge, then the payor is going to look out for the payer, and there's not going to be any record of them saying, yes, you can change the contract terms or amend the contract terms ad hoc with these spreadsheets appeal. They're going to try to use it against you. So we highly recommend that you get it in writing. Now, I have two other points that I wanted to talk about, two other topics. One topic has to do with the fact that payers are using the COVID crisis as an excuse to delay litigation. And we have a very specific strategy that we have come up with in order to help take the power back from the payer and give it to the hospital to force the payer to come to the table and to negotiate, if possible, or at least to be ready to negotiate and have evaluated your claims. A third topic actually, has to do with the use of video conferencing with depositions and arbitrations. Now, in order to allow for some Q&A and for this seminar to go on, I believe I've already reached my time limit, so we can leave those two topics for Q&A. If you want to talk about how we can fight against the payers delaying the litigation process and using COVID as an excuse, just go ahead and ask questions. Or if you want to talk about using video conferencing technology to conduct depositions or arbitrations, please submit your questions to the Q&A. Thank you.
Thanks, Dave. And thanks to all the panelists. If I could ask them to join the video, Dr. Zarate and Chuck. And also what we'd like to do is sort of enter the question and answer phase. I've got some questions for the panelists, and I would also encourage everyone to use the Q&A function, which is down at the bottom of your screen. We have one question, which is a great question. I'm sure we're going to be able to get to it, but anybody else that has that, just type in your questions and they come to us, and then we can present them to the panel. And we appreciate that. Great presentations, everybody. I had a couple of follow-up questions. David, to start out with, in terms of expediting resolution of the claims, and you talked a little bit about electronic arbitrations. I know that in our practice, we've been trying to get that process going for many, many years outside of the context of the coronavirus. Yeah. Could you talk about the advantages and the disadvantages of being basically forced to use a Zoom type meeting like this in arbitrations, mediations, depositions, and how that actually benefits the providers in terms of expediting recoveries?
Yeah. In fact, Rich, yeah, we have been advocating for the use of video arbitrations and even for depositions. We've done many of those, in fact. And recently, in the last couple of months, we've done a significant number of arbitrations using the video conferencing technology. So one of the things that we're finding is that the clients are tending to somewhat shy away from the use of video conferencing. But I want to assure you that using the video conferencing technology to conduct an arbitration is very, very simple and has a lot of advantages for you as the representative testifying on behalf of the hospital. For example, you don't have to get in your car or get on a train and travel to downtown Los Angeles to the AAA or JAMS offices. You save a lot of time that way. You can have all of your notes directly in front of you. You could have your computer screen with all of your work directly in front of you. And that's something that you can't have if you were sitting in a AAA office or a JAMS office before an arbitrator with the attorney on the other side. Now, the other advantage to doing these arbitrations electronically is that you don't have to spend the whole day outside of work. You come in, you testify, you get it done. It's the same thing with a deposition. You don't have to travel there and back, but you can use the technology in order to conduct the process. And it's just like you can see right here. If Rich was the arbitrator and Dr. Zarate was one of the attorneys, it would be exactly like what you're looking at right here. Same type of technology that is used with different platforms. One of the drawbacks that we have found, and there's just a couple, is one of them is that I can't be seated right next to you. So if you have a question, we have to work out a system of using electronics, whether it's text, whether it's private chat, whatever it is. The features are used have that on the technology itself. So the attorney that's representing you is not next to you. Another problem with that, and I've seen this on a couple of arbitrations, especially with experts who deal with a very large amount of material, is they can't sometimes find the right exhibit. If we're asking them to look at a certain exhibit, they're searching around trying to find it, and nobody is there to help them. And that can be a time delay. The other issue is that some of the arbitrators are they're old school. They have always conducted arbitrations using paper. So typically, when we go down to a JAMS or AAA arbitration, behind us, we will have 30 to 40 binders filled with documents. And the arbitrator will have their own 30 or 40 binders filled with documents. And the opposing counsel will have 30 or 40 binders filled with documents. And everyone has to grab one and go through it and all that. The beauty of the technology is that we can do all of this electronically. The arbitrators, being somewhat electronic phobic or technology phobic sometimes, tend to shy away from using all or pure electronic form. However, each of the arbitrations we've conducted so far, the arbitrators have agreed to use electronic documents, and they have found that the electronic document use has been much faster than using the paper. So those are three things that are drawbacks to using the technology, but we're getting better and better and better at it each time we do it.
Has it also impacted the payer's ability or disability to delay the arbitrations in terms of when the virus first hit? It seemed like we were getting hit every day with continuance notices of previously set arbitrations. And all that does is it benefits the payer because then they're not compelled to pay anything on the claims. Now that the electronic aspect has been adopted pretty much universally, those arbitration dates have become much more solidified. We're not continuing arbitrations. We're continuing to put the pressure on the payers to continue to review and to resolve as many cases as they can immediately. We're also setting up electronic mediations, which are a little different than arbitrations, but they often lead to large numbers of claims being able to be resolved at one time. So there is a silver lining with regard to the virus and how we've been forced to work. And I think going forward, it's going to benefit us tremendously because the expedited aspect of resolution doesn't have to be abandoned once hopefully the virus impact is going to be lessened. So I think it's really a really important type of thing. The other aspect of it is, of course, that when we're dealing with claims from around the country. So if we've got a California hospital that treats a patient from Illinois, for example, we can litigate in Illinois, and the impact on the witnesses from the home facility is lessened because they can testify electronically as opposed to having to come to Illinois to testify. So overall, it really is a tremendous advantage, I think, and we're looking forward to the future and able to do that. So thanks, Dave. I appreciate that.
Absolutely.
Dr. Zarate, let me kind of switch gears a little bit with regard to this. In terms of your case management work and background and your current work with regard to that, how do you feel that the sustained virus-related employment issues will impact case management?
I think what we've seen is furloughs and flexing, and unless there is a significant rise in the patient hospitalizations, we're going to continue to see that. My worry with that is that as people are considering different careers and burnout with physicians, I think that may trigger an efflux of healthcare providers. So at this point, I'm concerned about that.
In terms of your interactions with the payers, do you reach out to the payers to try to work out more JOCs or direct contact with them to try to expedite the process of processing clinical denials, anything like that? And have you noticed that the payers either have or have not loosened up their approaches to clinical denials because of the impact of the virus?
Unfortunately, what we see is I do handles peer-to-peer phone calls, and thus far, because it takes 3 months or so to get them in front of you, I haven't seen any cases related to COVID denials. But they are participating in the peer-to-peers, and I'm pretty successful with the conversion of the denial to an approval.
My question was actually a little bit broader than that, not just the COVID-related denials. You know, whenever we are advising clients on large inventories of unpaid claims, the first step is usually, from the client standpoint, they want to reach out to the payer and try to work something out, because the culture has somehow come to the point where the payers want to come across as a partner in this whole industry. I'm wondering how much they've stepped up as a partner, not in COVID-related claims itself, but in the overall impact of the pandemic on the revenue cycle, the cash flow, the revenue reimbursement that hospitals have had. Have you had any of the payers reach out to you and say, we know you guys are hurting, what can we do to help?
Thanks for rephrasing the question, Rich. I have not. And it's usually the other way around. It's the movement from our revenue cycle towards the payer to get them to agree to change their denial.
Yeah. We've kind of seen that across the board. I've heard of things like payers stepping up and putting out large amounts of money as sort of a prepayment type of thing, but they're not giving up on the review process, meaning that, yeah, we'll give you a significant amount of money because we know you're hurting, but we're still going to review the claims with a fine-tooth comb. We're still going to hold you to every contractual obligation that you have. We're not really going to loosen up or even adapt to the obvious impact on hospitals in terms of staffing, in terms of everything else. It just doesn't seem like the payer community, despite what David said with regard to their basically maintaining their financial superiority with regard to it, they're not really stepping up in this regard. Is that pretty much your experience?
That is my experience. I think the waivers are dangerous. I think we still have a responsibility to document appropriately, even in the Medicare population, because even though they say they're going to waive, there's still review. I haven't experienced what will happen afterwards because they haven't been there, how lenient they're going to be. But I think the commercial payer is definitely not going to respect those waivers. And I think we still need to document appropriately and be on safeguard.
There's absolutely no question about that. And as David brought up, the spreadsheet appeals, which is kind of thinking a little bit outside the box and outside of the black and white terms of the contracts. And if the payers are responsive to that and you're able to set up ad hoc processes for getting rid of a lot of claims, a large number of claims at the same time, be very, very cautious in terms of continuing to maintain compliance with your contractual obligations, because we've seen it over and over and over again where JOCs are set up or special committees are set up by the payers and the provider, and they're going to be friendly and work out large inventories of claims. When that breaks down and official action or formal action has to be taken, suddenly every appeal, every meet and confer, everything that had to be done under the contract is now invoked by the payers. There's no, cutting any slack in that regard. So they kind of lull you into a false sense of security sometimes when they're being cooperative with you, because it's kind of out of character in that regard.
Exactly.
So, yeah. So thanks, Doc. Chuck, you talked about telemedicine, which again is, I think, a really burgeoning area. We have a question from one of our friends, Noel Coppinger. I don't know if you can read it in the Q&A thing, but I'll read it for everybody who can't. Telehealth question: are you allowed to bill the hospital component of a telehealth visit if the physician was in the hospital grounds performing the telehealth visit? It's our radiology oncology department that is providing these telehealth visits. We are already billing the physician visit, but wanted to know if we can also bill for the hospital part, and if so, what codes to use. So Chuck, if you can address that, and Dr. Zarate, if you have any input, anybody else on the panel, anybody that has any input in that. Go ahead, Chuck.
I'll leave the coding to Dr. Z. He might be able to input with as far as that. But yes, the biggest issue that with respect to telehealth that's going to draw the flags and where there's the largest concern is that there's concern when a physician is doing the telehealth portion and then having the patient come to the facility the same day. That draws the red flag, and that's a no-no in the telehealth in terms of reimbursement. So as long as you're doing the same exact services where the physician is not going to matter in terms of they're going to bill for the services that were rendered. And yes, it's just as if you were billing at the hospital. Now, the biggest difference is that you're not, since there's no physical interaction, there's not the ability that you're going to have any of the, I guess, tertiary, the other hospital things that you would have been billing for, other than the advice that's being provided. So there's obviously no medicine or treatment of any kind other than you're doing the examination. But with respect to the codes, I'll let Dr. Z address that, because this is something new with respect to the mass amounts that are being billed right now. So Dr. Z.
Thank you, Chuck. To answer the question for Noel, my initial review of the waivers for Level 53 waivers, you would be able to bill the hospital component. I will review that and we'll give you a more solid answer just to make sure that we're being compliant. But the initial review really waived, the initial waiver really suspended the restrictions on the billing. They're allowing a lot of flexibility as far as a billing is concerned, Noel. So I think that virtual medicine is one of the silver linings that came out of this, because I think we're going to see a big shift towards patients seeking virtual help. You're limited, and I would caution that you would lose important information because you're not doing a physical exam. But they're getting very creative with generating lung sounds virtually, so you can hear them, your weight, heart rate, blood pressures. So a lot of that is actually becoming integrated into phones, that it can be transmitted via Wi-Fi. So I think it's one of the silver linings, and we're going to see more. I am concerned about what Chuck mentioned, that there is an excess in billing that is out of proportion to the amount of hours in a day. And we're going to see more in that regard.
I agree, Doctor. Telehealth is this burgeoning area, even outside of the COVID context, no question about that. And I actually received several calls from clients late last year with regard to the relatively new passage of a law that strengthens the ability of hospitals to bill for telehealth. You have the ability to bill just as if it's an in-person examination. One of the interesting things that came up was that a few of our clients have contracts with a particular payer that restrict the use of telehealth to an individual vendor. And the way the statute was written is that it's prohibited for a payer not to honor telehealth billing simply because it's telehealth, unless there's a contract impacting on that. That's not the exact wording of the statute, but there is a contractual context that is introduced into the statute. And if you've agreed that the only coverage or the only telehealth that you can bill for is through a particular vendor, then that is an agreement that's limiting your ability to do that. But outside of that, you should be able to bill for anything that you could bill on a face-to-face basis. So that's one thing to look for in your contracts, to make sure that you're not letting that in or you're limiting that as much as possible.
Hey, Rich, let me add, you bring up a great point with respect to contracts. With this wave that's occurred, this is something that should be on the radar as well, that you're going to see probably a lot of the major health plans introducing into your next contract negotiations telehealth and some procedures and reimbursements. Remember, you can contract anything. So even though there's federal laws and state and local laws, you know, be on the awareness that this is coming, that there's going to be an introduction into future managed care contracts, specifically addressing the provider's telehealth and what you can and cannot do and how it's going to be reimbursed.
Right. Yeah. Okay. Very good. Let me throw something out to the panel. You know, in these relatively unusual times, hospitals are attempting to come up with alternative ways of increasing their cash flow, increasing their fundings. As a matter of fact, there's even reports of hospitals using GoFundMe applications to try to do that. What are your thoughts with regard to that? what are the upsides, downsides to using some sort of really, really alternative funding mechanisms for hospitals?
Well, Rich, I think that the GoFundMe was one of the genesis for that. Was we saw a lot of hospitals were reaching bankruptcy or closing stages, especially the rural hospitals, and they were turning to that as a potential alternative with there no other major donors that could come forward. The issue in this country now is we know there's approximately 35, 45 million people unemployed. So it's really challenging to be turning to your public for money in this day and age. So even if you're a community hospital, it is a challenge for them to turn to their local community and say, hey, we'd love to stay open, but can you provide us some additional funds? But that is a time where the hospitals need to be looking again for additional revenue streams and thinking outside of the box. Again, telehealth is one of those potential avenues. There's other avenues that need to be explored in addition. Dr. Z might be able to address it, but hospitals are open 24 hours a day, and perhaps the way of scheduling surgeries, once the elective surgeries are allowed, will need to be addressed. Perhaps there's going to be the ability to have more surgeries in a day and looking at the less risky surgeries taking place in off hours, coupled up with telehealth that could then do the follow-ups once the patient could be discharged immediately following their surgeries. But I'd let Dr. Z address those.
As far as elective procedures, I think some of the hospitals in our area have already started to increase the numbers, but it's time consuming. Patients need to be checked for COVID positive. The placement of the patients is important after the fact. So I think at least now, while the wave is in place, as far as location of care, we may be able to take care of some of those elective procedures elsewhere where it would be safer for the patients. Long term, would have to come back into the hospital when the 1153 wave is removed. But at least for now, that may be an alternative to generating revenue.
Doctor, do you have any suggestions as to what alternative facilities could be used in that regard? Are you talking about ambulatory surgical centers, or what specifically would you recommend?
Exactly. More procedures are being moved from an inpatient status to outpatient, and even some of the delicate procedures like knees and hips are now considered outpatient. Some of them are leaving the next day. It's not even earlier. So I think more procedures may be able to be performed in the ambulatory center. Unfortunately, now that really impacts revenue, but with the waiver, you would still be able to bill under the NPI of the hospital being performed on the hospital premises. So right. For the time being, that may be an alternative to generating revenue.
Mm-hmm. Okay. Let's switch gears a little bit again. Let's talk a little bit about some employment issues that come up because of the approach to declining revenue. A lot of companies, not just hospitals, have invoked things like layoffs and furloughs and split shifts and things like that. From a health standpoint, from just a wellness standpoint, I know, Joy, you've done a lot of work in that regard through PH Labs and through your other work and that type of thing. In terms of maintaining good morale, let's say, within an employment context with the reduced staff and the social distancing and things like that, what recommendations would you have for folks in terms of trying to maximize the productivity of the people who are actually working in the office, or even those that are working remotely from a general health standpoint?
There's so many studies that are done, Rich, that focus on how to take care of ourselves so that we don't fall prey to much of the diseases such as coronavirus. So I think as healthcare providers, we too need to educate our staff on how to take care of ourselves beyond just wearing the mask and beyond the social distancing. There's research supporting that. For example, vitamin D and vitamin C and a bunch of other nutrients are necessary, and that we have to be proactive about taking the steps necessary to protect ourselves beyond the physical barriers that are recommended. And perhaps we don't talk about that much. Or government doesn't seem to emphasize that as much as they do social distancing. And I think both aspects are important. So as healthcare providers, I think that's something we too need to emphasize, that there are other things that we can do to keep ourselves healthier beyond what's traditionally recommended.
True. I think one of the ways that we had traditionally done it at SAC would be on Fridays or toward the end of a week, we would have group lunches in the break room. People would bring in treats and things like that. From your recent blog article, I got the distinct impression that's not something that you would endorse. Can you talk a little bit about that?
No, I would much prefer that if we're going to do things, we do it outdoors. As you know, at SAC, we have been lucky to have been aware of the importance of working remotely for years. I think since 2020, since the year 2000. So we were mostly offline when COVID hit. So I think at our firm, we probably have about roughly about 15 people, 10 to 15 people on the entire floor, if that many, and not at the same time. And the reason we were able to do that was because we understood the importance of remote access, recognizing that there are going to be times when if we have kids, we're going to have to work from home, unfortunately. If we have emergencies, we can't come into the office, or if we're have a far distance to go to work. So I think SAC was situated to address these issues when COVID hit. And with also the fact that we had electronic medical records and electronic, files that we could read and review at home, et cetera. So we have not had to deal with the paper issues as much as many other firms have. But I think these are issues that all law firms and all facilities will have to address as well in the COVID era.
I also think there's lessons that we learn from this era going forward. Again, optimistically, when we get past this, and I'm sure that we will at some point, there's a lot of really good takeaways from how people have adapted to this. And one of them is what you were mentioning, Joy, is the ability to work remotely. And what the virus has done is it's basically forced us to examine what the limits of that are. And they're a lot broader than I think we ever anticipated, that it is something that can be done, that and done even more efficiently than from a face-to-face standpoint. Now, there's no substitute, of course, for face-to-face interactions and that type of thing. That's never going to go away, certainly not from our standpoint. But it really has expanded our ability to serve our clients across the country, to keeping in touch with them and interacting with them and that type of thing. Let me just go around to the panel. We've got just a few more minutes. Let me go around to everybody on the panel, and if you could have one takeaway from the seminar that you'd like to impart to the audience, let's do that. Dave, go ahead.
Yeah. Thanks, Rich. I think one of the biggest takeaways is understanding that this is a time of uncertainty, and it has been thrust upon us to have to deal with a huge situation very quickly, to make quick decisions. So as Joy was talking about the mental health issues regarding employment, we're looking at employment that is transitioning. I hear all the time, this has caused us to have to think about things in a different way, to use electronic means that we were talking about before, to cut down on floor space, maybe to transition companies. And there's going to be ramifications from those decisions that I think communication at a very, very high level has to be maintained. So whether it's how do we facilitate appeals, if there's communication on that issue, how do we generate cash flow? How do we work with the federal government? How do we do these things? Communication is the #1 resource that we have, and it's free. And we have many ways to do it. So that would be the one big takeaway, is anticipate that there's going to be more problems or situations that you haven't anticipated down the road, that communication right now can maybe help stay away. So
Great.
That would be my one takeaway.
Okay, thanks, Dave. Dr. Zarate?
I think I'm going to address this in two different ways. One, at a personal level, I think that we probably thought this would never happen to us, so now we're living through it. I think personal preparation is really important. Family, home, understanding the details about the infections and how to protect yourself and your loved ones, especially if you're a healthcare provider and you're among a more risky environment. And two, from a professional level, I think that planning out surviving 3-6 months from a cash flow perspective is something many physicians and large organizations never really probably thought as a big risk, and now we're living it. So I think excellent planning is going to prevent this from occurring again, and it's going to ensure survival of the people that plan the best for unexpected events. That would be a takeaway.
Great, thanks very much. Chuck?
Well, I'm going to build off of what David had to say. I think communication is key, and especially moving forward with providers, communication with the patient. That is your ally. We can only go back to 2007, 08, and 09 when we saw a recession, and that provided a lot of hiccups for providers with respect to what the patient's health plan coverage was. A lot of people were unemployed or switching jobs, switching plans. So it's vital that you have a great communication stream, if not already set up with your patients. So communication is easy, and you can reach out to them and make sure you have all the best information that's going to make it that much better for your revenue cycle.
Great, thanks. Joy?
I think one of the things we need to do as a provider representative is to also be aware of the impact that this virus has taken on that community as it relates to nurses and doctors who might likely get ill, or employees who might likely get ill, folks, etc. It's going to have an impact at some point. And we need to look at our, within our organization to determine how can we make their lives easier. Understand that you might not get responses quickly because they're having, employee issues as well. And one of the things that we've had to do as a firm is, figure out how we can help. Maybe if an arbitration is coming up as an example, if we need to get something filed and we have the permission to file, go ahead and see how we can facilitate that quickly. Maybe file ahead of time, and create some arrangement that may work for them. Be aware of what their needs are. Sometimes we focus on what our needs are, and we don't look at what their needs are. And I think that's critical, especially in these unusual times. So maybe those are some of the issues that we too need to address. Maybe if it's advancing fees, if it's ensuring that we take that extra step when we don't get a quick response, because their staff, is going to be severely affected as well, and has been affected. So one of the things I think we need to do is just take a step back and don't think of this as business as usual in a law firm setting, and do what we can to facilitate their needs.
Great, very well said. Thanks, everybody. We're a little bit out of time in terms of the time of the seminar. I would encourage everybody who attended to continue to send us questions. Again, over here, website, contact us. You guys remember Dr. George Fishbeck, the weather guy? He's probably long gone. Anyway, we'd love to hear from you. And contrary to the way the payers come across as they want to be your partners, you know that we have been your partners for over 30 years, and we will continue to do whatever we can to help you out in whatever way we can. So thanks everybody for participating. We look forward to being able to come out and see you very quickly or very soon. And please stay healthy and happy. Joy, do you have any closing remarks?
And thank you all for joining us. It's been a pleasure serving you for 30 years. We look forward to doing this with you as long as possible. And we hope you all stay healthy and safe, because we need you to keep us safe. Thank you.
Thanks, everybody.
Have a good day.
Okay, bye-bye.